Hello and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. William Dale from City of Hope National Medical Center, Dr. Heidi Klepin from Wake Forest Baptist Comprehensive Cancer Center, and Dr. Supriya Mohile from University of Rochester Medical Center, co-chairs on practical assessment and management of vulnerabilities in older patients receiving systemic cancer therapy, ASCO Guideline Update. Thank you for being here, Dr. Dale, Dr. Klepin, and Dr. Mohile.
Nice to see you. Thanks for having us.
Then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including our guests joining us on this podcast episode today, are available online with the publication of the guideline in the Journal of Clinical Oncology, linked in the show notes. Diving into the content of this guideline, first, Dr. Dale and Dr. Mohile, can you speak to what prompted an update of this ASCO guideline on the practical assessment and management of age-associated vulnerabilities in older patients undergoing systemic cancer therapy, which was previously published in 2018?
Sure. Yes. In 2018, that was the very first guidelines for older adults that ASCO had created. And that was based on work that had been done up to that time, focused on chemotherapy toxicities. And to summarize what was put out at that time, the evidence was thought to be strong enough for doing geriatric assessments. And these are specialized assessments across a number of domains, including functional impairments, cognitive losses, social impairments, etc. But to do these kinds of geriatric assessments with validated tools, that a certain selection of these domains to cover everything that was relevant, to conduct non-cancer prognostication, so that for decision-making purposes, if someone were to have their cancer cured, what would be their prognosis and help make decisions about giving chemotherapy and what doses. And then to enact geriatric assessment guided targeted interventions was the fourth recommendation. And so that's where we were in 2018. In 2020 at ASCO, there was a oral session that had 4 randomized controlled trials that enrolled older adults. And that was kind of the signal that there was more coming. And in 2021, 2 big trials that are practice changing were published. One led by Dr. Mohile in Lancet that we call the GAP70 study. And another one was published in JAMA Oncology. And they essentially showed the same thing, which was that GA guided interventions could change the primary outcome, which was to reduce chemotherapy toxicity up to 20% and also to affect a number of other outcomes. That, along with a number of other trials that have since come out and are included in the upcoming guidelines, and made it a high priority to update these guidelines. So that's where we got from there to here. And I think it's worth saying a few words about these new trials, particularly the GAP and GAIN studies. So the GAIN study included patients who were 65 and older who were starting systemic chemotherapy and looked at the likelihood of having chemotherapy toxicity as described and looked at a number of other outcomes. Most importantly, it showed that chemotherapy toxicity could be reduced with these interventions based on the geriatric assessment from about 60% to about 50%. It also showed that the likelihood of completing advanced directives would go up around 25%. And importantly, there was no impact after all of the use of the geriatric assessments on mortality. So patients were living just as long, but they were having less toxicity and they were having more goal concordant care. And at almost the same time, the GAP study came out, which I would hand over to Dr. Mohile to describe.
Thank you, Dr. Dale. I agree that it was time for an update, and I'm glad ASCO partnered with us to do this. I'll also just mention that Dr. Dale, Dr. Klepin, and I lead the Cancer and Aging Research Group, and many of the original predictive models that showed that geriatric assessment could help us identify patients at highest risk for toxicity were designed by Cancer and Aging Research Group investigators. And that's what informed the first guideline. I'll mention Dr. Arthi Huria, who unfortunately passed away a few years ago, and she led some of the first large studies that developed these predictive models. We built on that data in both GAP and GAIN studies to show that the geriatric assessment, when you assess and provide management, can reduce chemotherapy toxicity. Like GAIN, GAP 70 plus implemented a geriatric assessment intervention that both assessed and provided management to older adults. There were some key differences. In GAP 70, the patients had advanced cancer, whereas in the GAIN study, it was a more generalizable population of patients with both curative intent and advanced cancer. And in the GAP 70 study, we enrolled patients who already had geriatric assessment domain impairments, meaning that these patients were more vulnerable because of those aging-related conditions. We were trying to enroll patients who are traditionally excluded from therapeutic clinical trials. The GAP 70 study was done in oncology offices by community oncology practices. So this was what I think was really interesting, in that geriatricians were not involved in implementing the geriatric assessment in this study. Oncologists received the assessment information from their team, and they're the ones that implemented the recommendations. We found in GAP 70 plus that not only chemotherapy toxicity was reduced, that we were able to reduce the prevalence of falls and reduce the incidence of polypharmacy, which are important geriatric outcomes for older adults. We included patients who were receiving chemotherapy, but also patients who were receiving high-risk targeted agents in GAP 70 plus, which also leads us to believe that these interventions are important for patients who are receiving treatments other than chemotherapy. So we believe these two trials plus others really inspired the ASCO guidelines.
Absolutely. I appreciate you both for providing that context and background and some of the new evidence that's informed this latest update. So then I'd like to move into some of the updated recommendations of the guideline. So Dr. Mohile, what is the updated recommendation from the panel regarding the role of geriatric assessment in older adults with cancer?
So the first guideline really focused on the assessment piece, what should be assessed and why, which we still incorporate in this new guideline. But this guideline extends now, because of the randomized controlled trials, into management. And when we think about geriatric assessment, we think about two pillars of management. One is how geriatric assessment influences cancer decisions. That includes what treatments to provide, what dose to provide. And then the second is how geriatric assessment can influence management recommendations that are supportive care based, that address some of the geriatric assessment domain impairments. I'll just give you an example of both. So when we see patients with advanced cancer who have geriatric assessment domain impairments, who are presenting for treatment, often the doses of chemotherapy may be over treatment because those doses were developed in therapeutic clinical trials in younger, more fit patients. And in our geriatrics world, we often think about going slow and starting low. And we may do a first cycle that's dose reduced a touch to kind of see how the patient does physiologically with that first cycle. There are therapeutic clinical trials like Focus 2 in patients with metastatic colon cancer that show the benefits of being careful with dosing in the first cycle. And so in GAP 70 plus, the oncologists who received information from the assessment were more likely to reduce the dose of the treatment in the first cycle, which led to less toxicity, but did not lead to a difference in survival. So it did not compromise survival. And I think this is because we don't know the right doses for patients who have significant aging-related impairments. So that's one example of decision-making. As examples for geriatric management recommendations that are supportive care, this can be done in almost like an algorithmic approach. So if a patient has an impairment on a physical function test, then through the geriatrics literature, we know of management recommendations that can improve outcomes like physical therapy, home safety evaluations, balance training, fall prevention information. And if we implement those supportive care recommendations for that patient who's at risk for falls, we may prevent falls. And we were able to show that in addition in GAP 70, as well as other trials showed benefits in some of those outcomes. And so those are the two pieces that I think really are newer with this guideline than with the previous guideline. We know more about how those management recommendations can improve outcomes.
Understood. Yes, it's helpful to understand those examples of how integrating this geriatric assessment can help improve the management of care for these patients. So then you've mentioned some of the geriatric assessment domain impairments. So Dr. Mohile, what does the guideline recommend should be included within a geriatric assessment?
This was a really great question for us to rise and think about as part of this guideline. And as a panel, we went back and forth with all of the authors to try to think about what is the most streamlined number of domains that should be assessed? What are the highest priority domains that if you could only do a few things in a busy oncology clinic, which are the ones that oncologists should have to do? Because without doing them, they won't have relevant information to inform treatment decisions or to improve outcomes of their patients. And so when we think about geriatric assessment, there has been literature to show that almost all of the domains we do are important in identifying patients who are at risk of poor outcomes. These include physical function, cognitive function, emotional health, comorbidities, polypharmacy, nutritional status, and social support. That sounds like a lot, but we do many of those assessments sort of naturally in oncology clinics. There are just a few that are not done as standard. For example, it is not standard for oncologists to assess cognition using a validated screening test for cognition. And we know that recognizing patients who may have cognitive impairment is really important in identifying vulnerabilities and providing support systems in place so patients who are receiving treatment can go through treatment safely. Other things like just doing formalized nutritional assessment, really bringing in the caregiver, are done not in a standard way. And so what the geriatric assessment allows is for us to assess each of those domains in a standard way. When we're communicating to our colleagues in tumor boards, we can describe vulnerabilities in a standard way. And we're moving now past the eyeball test, which is different for different clinicians, and having more objective ways of describing health status to be able to have a common language across studies and in clinical care.
That's helpful to understand, moving past the less formal approach to geriatric assessment and making it more standardized. So then, Dr. Dale, this guideline offers a specific tool, the practical geriatric assessment, as an option for clinicians conducting a geriatric assessment. What is this tool and where can clinicians access it?
Very good question. Just to set the context a bit, after hearing about all the evidence that we've just described, we did do some work as a task force through ASCO and through some work that Dr. Klepin and her colleague have done to understand, now that the guidelines in 2018 had come out, like they weren't really being used. So when we asked, about 25% of people would say they were using them very much, even though we saw in these large studies that we did that those who were using the guidelines were changing their practice significantly in the ways that Dr. Mohile mentioned. And this was among a large group of community oncologists. So we have been breaking down the geriatric assessment into the most concise, most straightforward, and easiest to use version of the geriatric assessment, maintaining its validity and maintaining the number of domains. We really tried to make it simple. So the practical geriatric assessment is not the only tool, but it is a tool that accomplishes this practical charge to make it accessible to community oncologists while also being valid. So those domains that Dr. Mohile mentioned, physical function, functional status, nutrition, social support, psychological considerations, comorbidities, are all in the practical geriatric assessment. But what we've done is boil it down to, here's a very specific tool that we think is valid, but easily applied. Here are the very specific thresholds that tell you when a deficit has been identified, and then gives recommended actions to be taken, whether it's in decision-making or in other interventions, like a referral to somebody, perhaps physical therapy or a cognitive specialist. all of which come from the GAPS. So this tool is designed to be very straightforward and practical, but still cover all the relevant domains. And it will be made available through both the ASCO website and through the Cancer and Aging Research Group website so that people can access it easily.
That sounds like a real challenge that the ASCO working group took on to create a comprehensive yet practical tool for clinicians to use. We'll also provide some links for people to access this in the show notes of this podcast episode. So then I want to move on. Dr. Klepin, in your view, how will this guideline update impact both clinicians and older adults with cancer?
Yes, thank you. As was mentioned, for clinicians, the guidelines provide an overview of new evidence and concrete recommendations to address the challenge experienced every day in practice, that of providing personalized care in the context of age-related conditions to maximize benefits and minimize the risk for older adults with cancer. The evidence summary will educate clinicians on key outcomes that can be positively impacted by use of geriatric assessment, including decreasing treatment toxicity, enhancing decision-making, and improving communication and patient caregiver satisfaction. And this information on outcomes is really critical to informing the use of geriatric assessment in practice. We hope that the evidence-based recommendation with the provision of the practical geriatric assessment and the associated trigger table to guide management strategies will empower clinicians to incorporate geriatric assessment into their workflow by helping them overcome some of those known barriers that Dr. Dale mentioned, such as lack of time and uncertainty about which measures to use and what to do with the information once you have it. So we anticipate that providing clear recommendations and accompanying readily available materials to support the implementation, that clinicians in both community and academic practices will be able to use the geriatric assessment and incorporate it into routine care. For patients, we anticipate that the guideline recommendations would translate into increased use and access to this type of assessment as part of their routine oncology care. So we hope that our patients will actually be able to access this regardless of whether they're receiving care at a specialized academic center versus a community oncology clinic. So by doing this, we would extend the proven benefits of geriatric assessment, including lower rates of side effects, experiencing fewer hospitalizations, and improving satisfaction to older adults regardless of where they receive treatment. And we feel like this is critically important since currently most older adults receive cancer care in community oncology clinics without access, as was mentioned, to any geriatric specialty care. So as more older adults have the opportunity to participate in this type of assessment as part of routine care in their oncology clinics, they'll be able to discuss the results of the assessment with their healthcare providers, which can help them make better informed decisions and engage, I think, more completely in what we would consider patient-centered decision-making. And ultimately, we would hope that the guidelines would provide an evidence-based and practical strategy for improving the quality of care received by older adults with cancer. Dr. Dale, would you be interested in commenting a little bit more on the patient perspective informed by our patient partners on the guideline panel?
Yeah, thank you, Dr. Klepin. Very well said. Yeah, our guideline panel, just to fill out the picture of that, included our patient partners along with a wide diversity of perspectives. We had experts in geriatric oncology, but we had community oncologists who take care of cancer patients. We have people from across the country. We had different backgrounds and different levels of experience. But to focus on the patients for a group that we've worked with for some time called Scoreboard, and they were some of the strongest voices on this. Whenever people said, well, do we really need to require this? The patient partners were insistent that this be included as a requirement as much as possible for what happens. I think one of the most important roles they've played is as advocates for this. If I can, when the community oncologists are having some concerns about this, how hard this would be or how difficult it might be, the patient partners have been the first to say we need to find a way to do it and insist that we empower the patients to ask for it. So one of the hopes for all of this guidelines is also that it get disseminated to patients who can self-advocate as they go forward and have tools that will be made available for them to use in this self-advocacy.
Definitely, that self-advocacy is important, and the geriatric assessment is critical for optimal care for older adults. So then we've talked a lot about the new evidence regarding geriatric assessment and also making it easier for clinicians to implement the geriatric assessment. But Dr. Klepin, what are the outstanding questions and challenges regarding geriatric assessment in older adults with cancer?
Thanks. So while there's strong evidence and clear rationale to incorporate geriatric assessment into routine clinical care, there are outstanding questions and challenges that we have to consider. First and foremost, still remains a challenge of implementation. As mentioned, we hope that the practical geriatric assessment, the detailed recommendations, and the associated educational materials on what to do with the geriatric assessment information will help overcome implementation barriers for many. But we recognize that more work needs to be done to both train providers to facilitate behavior change, as well as to tackle clinic and healthcare system barriers to routine use. And along these lines, we also recognize that it's important to educate patients and caregivers about the role of geriatric assessment and its value in order to optimize uptake in community clinics. We want all of our patients to be as enthused and recognize the importance of the geriatric assessment as our colleagues on the recommendation panel did. Another consideration is the challenge of tailoring use of geriatric assessment to specific disease and treatment settings. And more research is underway testing geriatric assessment and management strategies in varied disease settings, as well as with varied treatment types and intensities. And finally, I would suggest that another challenge is the lack of routine incorporation of geriatric assessment measures into cancer clinical trials. And this will really be necessary to interpret clinical trial data for older adults optimally and to reinforce the value of routine geriatric assessment in clinical care.
Absolutely. These are key points for moving forward and looking forward to additional research in this area and maybe future guideline updates down the line. So I want to thank you all so much for your work on updating this guideline and for your time today, Dr. Dale, Dr. Klepin, and Dr. Mohile.
Thank you for having us.
Yeah, thanks for having us here. We're delighted to be talking about this.
Thank you.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/supportive-care-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.